Okay, good afternoon, everybody. Welcome to our fourth and final seminar in this series of lunchtime seminars that the Division of Neuropsychology has been running over the last few weeks. My name's Simon Prangnell. I'm a consultant neuropsychologist in Oxford, and I'll be chairing the session this afternoon. I'd also like to introduce Katie Smiley, who's going to be signing for us this afternoon, and also to Catherine Carpenter, who's consultant neuropsychologist and chair of the Division of Neuropsychology. So in this afternoon sessions, we're going to pick up some of the themes that we covered last week, but start to focus more on other pathologies such as traumatic brain injury and tumours. As ever, I'll be monitoring the questions and answers and the chat, so feel free to post questions as we go along. I'll keep an eye on them, and then at different points we'll stop and take questions. Towards the end of the session, if you have any feedback, that would be very much appreciated, particularly if you have ideas for other seminars that you might find helpful that the Division of Neuropsychology might be able to offer. So please pass on your feedback. Anyway, so I'll hand over to Catherine and Katie. Thank you.
Thanks, Simon. So hi again, everyone, and welcome to the last of this mini webinar series. So what I was going to talk a little bit more about today was, as Simon says, traumatic brain injury and brain tumours, two pathologies that actually we see a lot in neuropsychology, and give you some flavour of working with them. I'm also going to pick up a little bit on some of the questions that we had last time and the time before, because I didn't have much chance to answer those. So traumatic brain injury, I think I touched on this a bit last time, that whatever you're doing, whether you're doing a neuropsychological assessment, whether you're doing some sort of neuro rehab intervention, whether you're helping support the person and their family and carers, you need to have a very clear idea about the severity of the injury. There isn't one thing that's a TBI, it's a whole continuum. I'm sure you all know this. So as we touched on last time, you need to get as much information as you can from interview with the person, from witness accounts, maybe even from police records if it's a road traffic collision, from the medical records, from the rest of your team. And you're looking first and foremost at biological markers. So the sorts of things we're interested in are duration of loss of consciousness for the index event. Then things like Glasgow Coma Scale, and whether the person actually required neurosurgery at any point, what sort of intervention they required, whether they were intubated and ventilated, that sort of thing. And then the markers that neuropsychologists are particularly interested in, which is retrograde amnesia. That's loss of memory following Rebu's law back from the index event. So do they remember the car coming towards them? Do they remember stepping off the curb? Do they remember their previous holiday? What's the duration of that period? The duration of post-traumatic amnesia, which is key for us. So that's the period from the index event, including loss of consciousness, but also including disruption of attentional and memory processes following recovery of consciousness. And with the discontinuity of medical care in hospitals, it can often be very difficult to determine that period, which is quite a key prognostic indicator. And I don't know if any of you have talked to anybody in PTA, but if you go onto a ward and talk to somebody who's very recently admitted who is actually in PTA, you can sometimes be surprised that they seem pretty compos mentis. They might even tell you that they've been in a road traffic collision. But were you to go back and speak to them maybe 4 hours later, or even 2 hours later, they probably wouldn't know you. They wouldn't remember the conversation. They wouldn't know that you'd spoken. So it's disruption of the laying down of ongoing day-to-day memory, and that's what's important. And sometimes families and carers even talk about their relative having sort of woken up. It's as if they become more compos mentis at some point. So that's a very important prognostic indicator. And then we're also interested in what we call anterograde amnesia, that is memory reduction once the period of PTA is over, which may or may not persist into the future. It may be prolonged as a memory deficit. And I mean, to give you a flavour, you know, I probably there's a bit of a gross generalization, but probably in the acute neurosciences, we tend to see more of what I call the walking wounded. We see more post-concussional syndrome and milder head injuries. That's not always the case. Certainly, patients are admitted with very severe head injuries, but then they usually go on into neurorehab settings, which is where we tend to see the more complex cases. But even concussion can be troubling and need a little bit of thought to see your way through it. One of my assistants actually, I mean, in Oxford, we have a lot of cycling, as you probably know, and one of my assistants, very unfortunately, was subject to a car door opening and knocking her off. She was wearing a crash hat and everything, but I think she was taken aback to experience over some weeks these symptoms that we call post-concussion syndrome. There are a panoply of things like irritability, confusion, dizziness, excess tiredness, slight nausea, a whole range of things. So just to give you one case vignette, I can think of a woman in her late 30s. She was the chief exec of a charity and she was snowboarding in Canada. And as often happens, you know, it was the last run of the day. It was getting a bit dark, not exactly dark, but less good visibility. And she came down hard on some very hard ice and cracked her head. And despite the fact she was wearing a helmet, she took one hell of a ding. Thought she was all right, a bit shaken, got home, had something to eat, went into work the next day, managed a meeting at 8. And then by 9 o'clock, her colleagues said, "My God, you look like death warmed up, you look terrible." And then began a whole panoply of these post-concussional symptoms. She was in fact very bright, very well supported, very grounded, and despite all these symptoms, she made an extremely good recovery in about 6 to 8 weeks. By contrast, I can think of somebody else that I worked with who was a publisher. He was a commissioning editor who used to travel around universities, speaking to academics as potential authors. And he was getting out of a minicab and reached into the boot for his briefcase and struck his head on the lid of the boot. And I mean, didn't lose consciousness, but saw stars and felt very shaken and had similarly a lot of post-concussional symptoms. And he was actually referred to me 6 months after the index event, which is a long time, and brings to mind a seminal paper by a neuropsychiatrist called Alwyn Lishman, who was at the Maudsley and who wrote a book, pretty old now, but it's been revised, called Organic Psychiatry. I think it's in its 3rd edition, and it's been revised by people like Simon Fleminger and Michael Kopelman and others. Very much worth a look. He wrote a seminal paper, and I think, you know, embarrassed to say 1988, called something like The Physiogenesis and Psychogenesis of Post-Concussional Syndrome. And I mean, his model has been somewhat updated since that time, but essentially what he was arguing...
Can you repeat that title, please? You just
yes.
The title.
Physiogenesis, so the physiological origins, and the psychogenesis, psychological origins of post-concussional syndrome. And what he's really arguing is at the beginning, there are a lot of biological factors at play, but if those don't resolve, it is in some cases because, as we've looked at in other conditions, pre-existing psychological problems maintain the issue. So in this man's case, he was actually in a very unhappy second marriage. He had was paying alimony. He had financial problems. He wasn't happy in his work. And I mean, again, I'm sort of caricaturing it somewhat just for the purposes of this webinar, to reducing it to the absurd. But in a sense, the concussion was a hook to hang his problems on. It was an acceptable way of saying, I'm not coping. And when we unpacked a lot of things and he began to see and began to understand some of the physiological processes and what else might be going on, he actually started going to relate and began to resolve some of those things. I mean, in fact, there are some studies that show that in a consecutive series of patients who haven't had concussion, who had other perhaps post-operative or a control series, you know, a lot of us have things like dizziness and headache and all sorts of things that are post-concussional symptoms, but you know, it's very easy to ascribe all those things to the index event, which many of us may experience day to day anyway. But of course, there are some very severe traumatic brain injuries, very tragic to witness. And particularly those with frontal lobe involvement are the ones where I think neuropsychologists are most critically involved. I can think of a young man who, on his gap year in Africa, was thrown out of a jeep. No, of course, no seatbelts, no helmet, no nothing, and was actually in coma for several months, and then in prolonged PTA. And I don't know, the tragedy is that he recovered physically extremely well. And actually, in terms of neuropsychological assessment, his cognition and his speed of processing, his language, even his memory were not very severely affected. But his executive functions, as we call them, his higher order faculties, which are subsumed in the frontal lobe, so things like, you know, we tend to call them executive because they're not just speaking, moving, remembering, they are Posner's forms of attention, visual selective attention, auditory attention, shifting attention, planning, thinking through the consequences of your actions. Those things were very damaged. And it meant that really he struggled. I think he went back to university, but managed to get a third with a lot of support from his parents. But then subsequently was really not able to attain either at work or in personal relationships as his peer group were. And it's very tragic to see, and needs a lot of input over a long period of time. Roger Llewellyn Wood's written a lot about the effect on marriages of you know, the frontal lobe involvement when you get sort of some degree of emotional blunting, and you know how that can affect family life. Audrey Daisley's done a lot of work on families and how much they need support and help after that. But essentially the roles of the neuropsychologist are the same, in a very detailed cognitive neuropsychological assessment at the outset, support with the cognitive deficits and management thereof. And I'm sure those of you working in neurorehab are more up to speed than me on all the digital supports and you know, devices that there are to help people ameliorate their problem. And things like errorless learning and backward chaining and so forth. We don't yet really have anything to restore function. Though, of course, there's a lot of redundancy in the brain. There are something like 6 pathways back from the eye to visual cortex, as you know. There are 3 main memory systems. So there is capacity for recovery. I mean, the brain's an amazing organ. And then, of course, there is, as we discussed in previous webinars, there's the emotional support that's needed. Any questions jumping in, Simon, before I go on to brain tumours?
No, nothing yet.
Okay. Brain tumours. So similarly, there's no one brain tumour. It's important to understand the severity, the extent, the prognosis. And I think, as we touched on last time, I find this benign malignant distinction in brain tumours a bit odd, but because really you don't really want anything in the brain that shouldn't be there. But brain tumours can be anything from the nastier forms of brain tumours, such as astrocytomas, the ones we call GBM, which stands for glioblastoma multiforme, which are very aggressive tumours, very infiltrative, that expand rapidly. And of course, the metastatic tumours. I can think of a patient who was actually being worked up to see if he was a suitable kidney donor for his wife. And in the course of the investigations, a shadow was identified on imaging, and it was, in fact, he was found to have melanoma of the liver, which had already spread metastatically to the brain, and he died of a brain tumour about 4 months later. But there are also a group of, so you don't want a brain tumour, but they're less aggressive. So the gliomas come in 4 grades. And in the course of my career, the management of these has changed. So when I started out and I was at your stage, neurosurgeons used to do watchful wait or surveillance imaging. And nowadays, the evidence seems to be that it's very important to debulk, to remove the tumour, or as much of the tumour as possible, as early on as possible. So the point being that with a few seizures or the relatively silent tumours, when they emerge, may only be grade 2, but if left in situ, these cells can transmute into a grade 3 or 4, which is obviously much more dangerous. So the point is that the optimal treatment is to remove as much of the tumour as possible without rendering an asymptomatic patient less able to remember, speak, use their higher mental functions. And neuropsychology is key for that. And in some centres, neuropsychologists are involved with awake craniotomy, which I think I mentioned before, which is where neuropsychologists join the surgical team, and the neurosurgeon will stimulate 2 points adjacent to the tumour and see if that a task that the neuropsychologist is administering is disrupted, in which case the neurosurgeon knows not to encroach on that area, or it might affect memory or speech and so forth. But with all these types of tumour, as I've said, it's the assessment that's key, then the support in terms of any cognitive deficits, and then the emotional support. All of those are part of neuropsychology. It's not just test bashing, as we discussed in the first webinar. And then you can get the ones that tend to be called benign, things like meningiomas, which arise from the meninges, the coverings of the brain, which get infected in meningitis. And sometimes you hear colleagues talking rather more cavalier terms about these. I've sometimes heard surgical colleagues talk about sort of peeling them off, or they're thought to be less aggressive, but less significant. But of course, you don't really want anything in your brain that shouldn't be there. And some of them, meningiomas greater than the size of a sizable tangerine. And my understanding is that it depends how vascular it is underlying the meningioma, but also, the brain isn't, I caricatured it last week by saying it's a bit like a blancmange in a box, but it certainly doesn't spring back like a sponge if you remove the structure that was compressing it. Having said that, you do see patients who do remarkably well after meningioma removal, and it's a very varied population. I can think of a woman who last year had just one very nasty seizure in bed with her husband, which gave them both a shock. But she was in London. She was very rapidly investigated and operated on, and has made an amazing has had an amazing outcome. She's done extremely well. I think a bit of irritability, but really well. But is not actually. She's effectively retired. She's not running her own business in the way she was in younger years. So perhaps any problems less evident. I can think of other patients where really they've become quite apathetic. There've been quite a lot of problems post-operatively. So it's a mixed bunch. A suggestion to those of you who are assistants or trainees is, if you can, I would sit in with neurologists or neurosurgeons or neurorehab specialists when they're in clinic, not all the time, but just see if you can get in for a morning, because it's very interesting to hear how colleagues talk to patients, how they describe the problem to them. I think, as I've banged on before, neuropsychology it's a support specialism that sits within neurology and neurosurgery and neurorehab specialisms. So it's kind of important to understand the whole context. And I think it can be very useful to hear how other team members are talking to the patient about their problem. Any questions, Simon, before I go on to formulation?
No, still nothing.
Oh, well, I hope there's somebody there. I'm talking to somebody out there. Somebody asked, I think last week or the week before, about formulation and how that's shared with the patient. And I think Simon replied quite correctly that it depends very much on what the formulation is, what the content is, what you're trying to share. and the nature of the pathology in the patient. So obviously, if the patient is already very much cognitively compromised, it will affect what you're going to say to them and how you're going to describe the problem. But I still think it's important to involve the patient. And just one minor detail that I think is important to remember is that even patients who are severely amnesic will retain some sense of the emotional tone of the encounter. I remember being rather shocked when a research psychologist wanted to enter quite a few of our patients into a research trial, and the protocol was, I thought, quite onerous. And they said, well, it doesn't really matter because the patients aren't going to remember, are they? That's not the case. Patients do remember emotional tone, and I think it behoves us to respect that and remember that. Certainly formulation and the way neuropsychology works is very much about trying to achieve a shared understanding with the patient. And I'm amused when I think how much that has changed in my career. So I was remembering the other day that I think in my first neuropsychology job interview, I was asked by a professor of neurology, would I share the diagnosis with a patient who was presenting with a demyelinating condition, so something like multiple sclerosis. And of course, you don't share that immediately. You wait until the diagnosis is confirmed after a number of episodes. But nonetheless, my instinct would be to be honest and open with the patient. But I think I must have picked up from this colleague's body language that wasn't the right answer. So I think things have very much changed. And I think, I think we all struggle with perhaps some of our more brighter, entitled patients who come clutching stuff off the internet saying, I want stem cell therapy or whatever. But by and large, it's important to work with the patient to try and help them understand what's going on with them. And many times the neuropsychological assessment of itself is a form of intervention because it can demonstrate to people just where it is they're struggling, and you can help unpick that with them, and they can find it incredibly helpful and revealing and rewarding. So if the system allows, and I entirely appreciate that the NHS is super stressed and super under the cosh at the moment, and sometimes it isn't possible, but where it is possible, I think some form of feedback in person or over Zoom rather just in writing is helpful, though of course you might need to follow up in writing because our patients have cognitive deficits of one kind or another. Haven't really got time to go into functional neurological disorders. We touched a little bit on that last week with non-epileptic attacks, but that's a case in point where it's particularly important to help the person come on board with your best understanding of what might be going on with them, that they don't go away thinking you're saying it's all in their mind or they're making it up or whatever. Particularly important. It can also be important and interesting to decode with a patient what they've heard from a colleague. And often when we see patients when they've been seen by the neuro rehab specialist or the ward round's been round, or they've been at a goal planning meeting or something. And I think colleagues forget how, I touched on this again at an earlier webinar, that how we're, imbued with all the language we know about these conditions. They're, not, some of them are new to us, but by and large, in the main, they're not new to us. And although people may have encountered these things on television through documentaries and things, when it's new, it's pretty frightening. And for example, you hear colleagues use the expression lesion. I remember when I started as a psychologist myself struggling with what exactly is a lesion? They talk about lesions in the brain. I think that's a very good case in point. What is it? It's something anomalous tissue, or a space occupying lesion, or an area of necrosis, dead cells, something that shouldn't be there. But that's the sort of thing. And I think because of the power imbalance in, particularly if you go and see a neurosurgeon, the neurosurgeons, let's face it, are gods. They're up there with the cardiac surgeons, aren't they? It's quite hard to say, excuse me, I didn't understand. So I think a lot of what we can do as well is to help the patient negotiate the treatment plan, help them understand what's being said to them about their condition and so forth. unless there are any other questions, because we're coming to the end of the time, I'm going to finish up with a few final thoughts. Is that okay?
There's just a clarification about the name of the book that you mentioned at the beginning of the session.
Okay. It's by Alwyn, well, I think if you look up Alwyn, Alwyn Lishman, Lishman, Organic Psychiatry, 3rd edition. He's sadly been dead some time, I think, but the ethos behind his book was an excellent one. And there is a 3rd edition. It's probably quite old now. It's probably still 10 years old, but I think it's it gives a very good sort of flavour of how you put together sort of formulation, the background to some of these things. And I think it probably details his views on post-concussional syndrome. So I'm just going to finish up in the last few minutes by just sort of recapping, as we're at the end of the webinar series. What I've tried to do, I guess, is I covered in the first session some of the basics. I talked about the fact that assessment is a controlled behavioural sampling of a kind. We talked about how you can begin to think about interpretation, though you may not be there yet, looking for disconfirming evidence when you're developing hypotheses. We talked about formulation, how the whole person, the whole context is relevant, and not to forget your clinical skills. So don't be discouraged if you feel you've got to go through a doctorate in clinical psychology before you get to neuro, because all those skills are very relevant. I think sort of 2 of the key messages I was trying to get across were: do it intelligently. So don't just do the test by rote because somebody said do the test. Think to yourself, why am I doing this test? What's the point of it? How is it going to affect management? How is it going to affect my understanding of the patient? Are we going to do something differently as a result? And, you know, probe a bit more. I always remember being very impressed when my clinical supervisor said to me, we were talking actually not about an assessment, we were talking about, I think it was assessment. I think I've been doing some Socratic questioning with a patient with an anxiety problem. You know, I pursued and I said, well, what would be so terrible about that? And they said, well, they might die, you know, and she said, well, and did you ask them what was so terrible about that? And I didn't, because it seemed self-evident that dying is horrendous. But in a way, she was quite right, because often if you pursue that bit further, this is a slightly trite example, but you know, what is so terrible about that? Well, I wouldn't be there for my children, or my partner would miss me, or you know, whatever. And then I think the second and most important thing is it's okay not to know. I think one of the tragic things is that, well, maybe you're not like me, but I read experimental psychology at Oxford, and I did arts A-levels. And so I always felt on the back foot sort of scientifically. And I think my worst mark was in the perception paper. I think I must have sort of Gamma Plus or something. But actually, when you're training and when you're an assistant and when you're, you know, a doctoral trainee, it's okay not to know. And I can't remember if I mentioned this in an earlier webinar because I'm probably dementing, but I'm always impressed by it's the Harvard professor at the back of the seminar who says, ooh, I've never really understood how PET works. Can you just run it past me? And, you know, I don't think I could tell you how positron emission tomography works, but, you know, I'd probably be too embarrassed to say that. When you're training is a time when it's okay not to know. And actually, even when you have trained, you know, there are many neurological conditions that are rare and unusual and not frequently encountered. If you just think of that, there's a wonderful table about the frequency with which a general practitioner encounters certain conditions. And I can't remember, it's something like headache they encounter, you know, however many times a week. And something like myasthenia gravis is once every 200 years or whatever. I mean, I'm making it up, but it's something like that. So somebody asked me a question last week about Friedreich's ataxia, and I had to look it up and look at the National Hospital for Neurology and Neurosurgery's website. And I'm not embarrassed by that because it's okay not to know. So just finishing up, final thoughts, you know, hope you've enjoyed these. As Simon says, if you've got any other ideas, somebody suggested last week that a case series might be helpful and interesting. Give us some ideas. Don't be discouraged by there being so much to know in neuropsychology. You know, Simon and I were talking yesterday about, you know, little and often. Just get the contents of neuropsychological rehabilitation or clinical neuropsychology and have a look at it. Just join the division. I mean, I would give a plug on it, but you get our update, which has a research digest in it, and it also has updates on clinically relevant issues and professional issues. And that's all helpful when you're going to be interviewed for DClinSci doctoral programs. So keep being interested, keep being informed. You know, read an abstract a week, and it will accrue. You will gain the knowledge. Anyway, I just saw a helpful suggestion there, but we've probably run out of time. And as I said, as Simon said also, if you've got any feedback, if you found it useful, if you'd like more of something and less of something else, then let us know, because it's a very different experience talking to a Zoom camera and seeing Katie and Simon and myself rather than seeing a room of people. So I have no idea whether everyone else has left or whether you're interested in making notes, but you know, give us feedback. Catherine.n.carpenter@gmail.com or Don social media. Thanks.
Thanks, Catherine. Thanks, everyone. Take care and have a good day. Bye.
Bye now.